So welcome everybody to another colorectal surgery virtual education evening. Thanks again for subscribing and joining us tonight. As always, if you have questions, please put them in the chat on Surgeon, or if you have our numbers, feel free to text either me or any of the leadership team. But tonight, I think we have an awesome talk, especially for some of you that are either going or just got back from the USC course, with Dr. Kristen Wong. Kristen Wong is an assistant professor in the Department of Surgery at the University of Alabama at Birmingham. She's a Foregut Bariatric and Advanced Endoscopy Specialist. And she's also our personal go-to when we're like, can you do anything for us with this weird thing that maybe there's an endoscopic procedure we might need? So I feel like I put in that consult pretty regularly now. She's a member of the Flexible Endoscopy and Foregut committees and has served as a faculty instructor for Flexible Endoscopy Courses for the Society of American Gastrointestinal and Endoscopic Surgeons. And her research interests include outcomes in therapeutic endoscopy. So with that, I will let Dr. Wong take it away.
Thank you so much, CBJ. And I'm really, really happy to be here tonight to talk to you guys. I know the title of my talk is very vague. What can the scope do for you? But generally speaking, what I want to do tonight is I want to take you past diagnostic colonoscopy and endoscopy and into the advanced therapeutic world and try to convince some of you why you need to include it in your practice. I have no disclosures other than that I am a foregut and bariatric surgeon talking to colorectal surgeons. So if I need to be corrected on colorectal literature, please let me know, and you can do that in real time. So I want to give you guys a little bit of background about how I got into advanced endoscopy and why I'm so passionate about it. So when I began residency at Montefiore Medical Center in New York, I wanted to do the big exploratory laparotomy cases. I thought the more involved, the better. I want to stand on my feet for 12 hours a day in the belly. And naturally, that lent itself to surgical oncology. So I did 2 years of bench research in cancer pathways. I thought I was on that path. And then when I came back to my PGY3 clinical rotations, I was scheduled to do my month of endoscopy with a gastroenterologist, and most of my fellow residents stood in the corner. Maybe they touched a few scopes during their 4 weeks, but otherwise they logged the minimal numbers required by the ABS, and then they actually didn't show up for the rest of the time. But I made it a point to start clinging onto this gentleman. His name is Dr. Sammy Ho, and he's an advanced endoscopist at Montefiore, and some people called him a cowboy. Others called him a genius. I would say he's probably a little bit of both. And he was doing a lot of cutting edge procedures. And yes, sometimes he had to be bailed out by the surgery team, but the majority of time he was helping patients avoid a more invasive operation. And I went every day of that rotation. And by the end, I was cannulating bile ducts. I wouldn't say I was good at it, but I did it, performed EUS drainage procedures. And I watched him do things like palliative gastrojejunostomy creations. And I kind of got hooked during that rotation. And that same year, I heard a talk by this guy. If you don't know him, his name is Jeff Marks. He is a pioneer surgical endoscopist from University Hospitals in Cleveland. And his talk about advanced endoscopy sealed the deal for me. So I went on to only consider MIS fellowships based on if they offered training in advanced endoscopy because I thought it was exciting, the wave of the future, and I thought it could help me to be the whole package surgeon. And that's how I ended up experiencing the coldest winter of my life in Wisconsin. And we had a baby during that time who had to be bundled up in multiple layers just to go out the door. And even the dog had to have a snowsuit to survive. So what is endoluminal surgery? And you're going to hear me say that a few times. There's not a single definition, but I want to take a moment to think about the evolution of our field. So for 200 years, surgeons have been performing laparotomies. Currently, we're witnessing the age of minimally invasive surgery. So whether that's laparoscopic or robotic, I mean, who wouldn't want smaller scars, fast recovery time, less pain, decreased surgical site infection rates, et cetera, et cetera. What we can now do through 5 to 12 millimeter incisions is nothing short of amazing. But I want you to imagine a world where if you have a surgical procedure, there are no scars. That is minimally invasive surgery, and that's what endoluminal surgery is. So today's agenda will include an argument for why surgeons like you guys should be performing advanced endoscopy. I'm going to include a little bit about the GI medicine surgery relationship. Then I'm going to take you and attempt to wow you with the examples of what the endoscope is capable of doing. And I'm sure you guys know some of these things already, but we'll take kind of a little bit of a deeper dive. And I guarantee you will find yourself needing one of these operations for your patients in the near future, or not operations, but procedures. And finally, we will discuss the future direction of surgical endoscopy. So why should surgeons be performing endoscopy? Why don't we just leave it to the gastroenterologists? For starters, surgeons were a big driving factor in its invention, the evolution of the modern day endoscope. In the late 1800s, what it involved was rigid tubes placed mostly into the rectum, and they were very limited by the lack of light. So you could only see so far into the rectum. Howard Kelly, a professor at Johns Hopkins University and former one of Halsted's general surgery residents, tried to solve the issue of light and visualization, and he described the first sigmoidoscopy in 1895. He devised his own set of instruments, including a sigmoidoscope, which was introduced with the aid of a blunt obturator, which I know you all are very familiar with. And the examiner wore a head mirror that reflected light from an electric bulb placed close to the patient's sacrum, as seen here. The early 1900s saw the development of the actual flexible endoscope that is looking more and more like the one we have today, but image transmission became a bigger issue. And this was University of Alabama at Birmingham's very own Basil Hershowitz. He added fiber optics to the gastroscope and devised a makeshift method of drawing out his own glass fibers, giving us the first flexible fiber optic endoscope, ushering in the modern era of endoscopy. And in 1957, he passed the prototype instrument down his own esophagus. And a few days later, he performed the first fiber optic gastroscopy on a patient. Who performed the first ERCP? That would be a surgeon, William McCune in 1968 while at George Washington University. And on the right, you have Hiromi Shinya, a surgeon who went on to develop techniques that allowed colonoscopy to be performed by a single endoscopist, whereas most commonly done at the time was a two-person technique. And he also conceived the idea for snare polypectomy as a means for avoiding exploratory laparotomies as a mean for polyp removal, which was commonly practiced at that time. Jeff Ponsky, who's also a surgeon and one of my personal heroes, is the inventor of the PEG tube procedure. His mother-in-law bought him his first endoscope, which he carried around in the trunk of his car. And here's an article from the local paper in Ohio reading, "Cutlass surgery is making strides and major operations bypassed." He was one of the first to push for surgeons to be performing endoscopies once again, when decades prior, the gastroenterologists had really started to stake their claims. And finally, this is a legendary surgeon here who's still practicing. Another hero of mine, Dr. Haruhiro Inoue, is a world-renowned endoscopist in Tokyo, Japan. And in 2008, he performed the world's first case of per-oral endoscopic myotomy, the first clinical case. And in 2014, he reported the world's first per-oral endoscopic submucosal tumor resection. And that's him right there. So surgical endoscopy is in our roots as surgeon physicians, but why aren't we all doing it? Where did the surgeons lose their footing in the endoscopic world? The first and probably biggest hurdle is reimbursement. So many of these new advanced therapeutic procedures do not yet have CPT codes. And as surgeons, our biggest asset is our time. Why waste it doing poorly reimbursed procedures? Then there is the issue of access. It's not efficient to take up OR to block time to perform endoscopies. And sometimes the turnover time ends up being at least 3 times longer than the procedure itself. Whereas in endoscopy suites, they're usually high volume, can do 15 to 20 EGDs a day in one room. And finally, there's training. So we have the fundamentals of endoscopic surgery, or FES as we know it, which became a mandatory part of board certification in 2018. That gives us the minimal number of endoscopies and colonoscopies that residents are required to do to graduate. But often, as you guys probably know, it's just treated as a checkbox, and it hardly makes us ready to advance techniques. Therefore, the reality is that GI medicine continue to do the majority of the endoscopies, including advanced procedures. And when you do a quick internet search about GI versus surgery endoscopy, here's what you'll find. Why choose a gastroenterologist over a general surgeon? Gastroenterologists do colonoscopy better. Maybe avoid these specialists for your next colonoscopy, and they go on to talk about how surgeons' outcomes are worse in terms of colonoscopy. And it was really evident when 4 national GI groups, including the American Society of Gastrointestinal Endoscopy, wrote a statement on our American Board of Surgery's mandated endoscopy numbers for surgical residents in 2011. They argued that it put a burden on the GI medicine attendings to train the surgeons and that the numbers required weren't nearly enough to become competent. So basically, they would have to clean up our mess. Of course, the ABS struck back with their own position statement, saying phrases like, the 4GI societies allege, and the position paper is erroneous and misleading on multiple points. But overall, this relationship between GI and surgery is and should be symbiotic, and we both need each other. They have a certain skill set that we do not possess, and vice versa. Besides the fact that endoscopy started with surgeons, the big push for us to be performing diagnostic and therapeutic endoscopy alongside GI, something that is clearly recognized by the ABS and other organizations, is because many of these endoscopic procedures are falling into the domain of surgeons. They require an understanding of basic surgical principles that we spend years learning. Surgeons have an advantage over gastroenterologists. We combine our knowledge of normal anatomy and surgically altered anatomy to better understand the disease process through the scope. We can also bail ourselves out of situations if something doesn't work or goes wrong. So I'm often consenting patients for endoscopic procedure possible conversion to laparoscopy. So now I want to pivot and talk about what procedures are out there, and I hope to give you a glimpse into what the endoscope can do. Here's a list to impress upon you just how many disease processes can either be completely treated or treatment augmented by endoscopy. And this is where I'm obviously going to focus on the colon. There's going to be a little bit of foregut thrown in there just to exemplify all of this, but we're going to go beyond the diagnostic colonoscopy. So a few important points, especially about equipment when you're thinking about doing advanced therapeutic procedures. So there's obviously many types of scopes out there, but the main difference that I want you guys to know is there's a diagnostic scope, which has one working channel, and then there's a therapeutic scope that has two working channels. You can do a lot of these procedures that I'm going to describe through the diagnostic scope with just one channel. I always use CO2 insufflation, especially because presumably we'll be working with defects or making defects in the bowel. So we don't want to put room air in the belly or mediastinum. I do always use general anesthesia for any therapeutic endoscopy case. And then I always use an OR table, not on the bed, just in case we need to use fluoroscopy, which we do quite often. Let's start with leak management. So successful management of gastrointestinal leaks and fistulae requires a tailored approach. So based on a clinical presentation and defect features, meaning size, location, and time of onset. This can be a staple line leak or an anastomotic leak. This can be foregut or colorectal. So anywhere you can reach with a scope. The treatment options follow basic surgical principles. You can either close it, drain it, stent it, or now we endoluminal vac it. And I usually consent patients for all possible indicated procedures and counsel them with the list of these things in order of what I think is most likely to happen and least likely to happen. For example, if it's a colorectal leak, you have to warn them that they may have a tube exiting their anus and it may stay there for weeks. So here's my algorithm for approaching a leak. The obvious first decision crossroads is, does this person require an operation? So obviously, if they have sepsis or peritonitis, they're going to go to the OR. But if the patient's stable, then is the leak acute, which to me and most of the literature means less than 30 days, or chronic? Acute leaks have a higher percentage of healing with endoscopic management when compared to chronic leaks. It's harder to get an epithelialized tract to close, as we all know. If it's acute, I lean towards closing it primarily. And so you can see that's the second part of the decision tree. Thirdly, size matters. The over-the-scope clip, for example, is indicated for full thickness closure defects less than 2 centimeters in size. If it's larger than 2 centimeters, you should consider things like endoluminal vac or stenting. And finally, is the defect clean or contaminated? If you have a cavity filled with stool or pus, you don't want to primarily close that right away unless you already have a percutaneous drain in place. And if you don't, I would try to place an internal drain, which is what you see called the internal pigtail drain, where one side's in the cavity, one side's in the lumen, and it saves the patient from having an external drain. So I'm going to take you through a couple cases that really show this management. So this was a 17-year-old male who sustained a gunshot wound to the right hip that went through his rectum, and he was treated with a diverting loop colostomy, but he developed a fistulous tract from his rectum to his right hip, which had resulted in infective necrosis of his femoral head. And it was a really bad case. He had to have it resected and antibiotic beads placed. And here's how the persistently looked on barium study on the left. We took him for a flexible sigmoidoscopy. We found the 0.5 centimeter defect in the mid-rectum. And now this is a video that is not this procedure, but it's exactly what we did. So you see them driving out into the cavity. They're going to clean the cavity because it's mildly contaminated, and this person already has a percutaneous drain placed. And once they feel that they've got it clean enough, they're going to go in with an argon beam coagulation catheter. So just to rough up the edges of the defect, de-epithelialize it so it kind of sticks together better and heals in better. And then you're going to see them go in with the over the scope clip, which is, I've shown you a picture on the top right of the over the scope clip. And that's again, indicated for less than 2 centimeters defects. So you can see what it looks like when they pull back the scope. Oh, we skipped ahead, sorry. There we go, right there. So that's what that clip looks like when it's on tissue. And here's a repeat barium enema study 1 week after our closure showing no leak. And you can see the clip in the X-ray picture. The ortho burn team were able to continually locally manage the right hip wound. A meta-analysis looking at the success rates of over-the-scope clipping for rescue therapy included studies over a period of 9 years and a total of over 1,500 patients. And the average clinical success rate was 78% overall. And when you broke that down by indication, 85% were successful for bleeding, 85% were successful for perforation, 52% for fistula. So you can see that the rate of success of clipping drops by about 30% if it's a chronic as opposed to an acute leak. 66% for anastomotic dehiscence. So the severe complication associated with clipping was only 0.5%. Here's closure of a colorectal anastomosis leak using a different technique. So this leak was chronic. The defect was first cauterized using an argon plasma coagulation catheter like we just saw. And this is a great demonstration of the Apollo overstitch device. So another way to close it, if you don't want to use a clip or if it's a little bit bigger than 2 centimeters, is to use this device. It attaches onto a dual channel scope. It's a needle toggled back and forth at the end, similar to an endo stitch if you guys have ever used that laparoscopically. And it can take full thickness bites. It can perform a running stitch or an interrupted stitch. And the attachment is shown on the right. This was a really big game changer when this came out. Moving on to a next case, an example of draining it. This was a 42-year-old woman who was referred to UAB for a chronic staple line leak after conversion from lap band to sleeve gastrectomy. So it is foregut, but bear with me. Initial management at the outside hospital involved an external drain placement by IR with initial improvement, and the drain was subsequently removed as the output lessened, and she became symptomatic again with right-sided pain, nausea, and fevers. I scoped her and I found a stenosis of the sleeve with a small, less than 1 centimeter defect just proximal to this. And I knew this leak wasn't going to close until we fixed this stenosis. And she did not want a conversion to a bypass. So we placed that double pigtail drain into the defect. So one side's in the cavity, one side's in the lumen, and then we serially dilated the stenosis. That didn't work, so we tried using an esophageal stent to pop the stenosis open, and that just can be placed over the drain, but that migrated and she had nausea. So I removed it, and then I ended up placing a lumen opposing metal stent, or and also known as an axio stent. That's the kind that normally they use for endoscopic cyst gastrostomies, and we left the pigtail in. When I went back to rescope her again, after placing the axio stent, the stenosis had completely resolved and she had reported eating normally. So we ended up removing the pigtail and closing that defect, which was very small now, with an over the scope clip. And lastly, talking about the endoluminal vac, I know you guys have probably had experience with this or seen this done, but this is of note. We don't have a prepackaged endoluminal vac kit available in the US, so we have to make it ourselves. And it's very easy to make. What you do is you take a black sponge, similar to what you would use on any wound dressing. You shape that into like a cone or a lollipop shape. You're going to cut the NG tube, usually an 18 French NG tube, and stick it through the sponge. And you want to make sure that the holes are all in the sponge and you don't have any that aren't in the sponge. You're going to suture that to the NG tube, and then you're going to leave an air knot at the end so that you can drag it through the intestine with a grasper. So an example of this is this was an unfortunate 50-year-old woman with a history of sleeve gastrectomy who developed a chronic proximal sleeve leak, which led to a ruptured splenic artery aneurysm. She was taken for emergent XLAP, splenectomy, washout, drain placement, and stabilized. They had tried to close the sleeve defect, but it didn't hold. And so we were consulted to try to manage her large sleeve defect, because you can imagine they didn't want to go back in this belly. And this is what it looked like the first time we scoped her. And so you're looking through a large 3 centimeter defect in the sleeve staple line and to a very big left upper quadrant cavity. We placed an endoluminal wound vac and we changed it every 1 to 2 times per week. And here you can see an example of what dragging a wound vac or dragging the sponge down looks like. So you're just using an endoscopic grasper, grabbing that air knot on the end of the sponge, and you're going to drag it down and place it into the cavity. So in foregut, the NG tube would go through the nose, and what you have to do is put the NG tube down the nose, pull it out the mouth, and then fashion the sponge on the end of it. For colorectal, obviously, you don't have to do that. But I would recommend suturing it into place on the outside externally of the anus. And so what did that look like over time? So this is over 8 weeks, and you can see that it's slowly granulating in. And what we did after that was she really did not love the idea of an NG tube, and she's had it for this point 2 months. And she really wanted to get out of the hospital. And obviously you could leave with an NG tube, but it's not ideal. So what we did is we switched management. We placed that internal double pigtail drain into the cavity, and we put an esophageal stent over it to cover the defect. She did leak around the stent proximally on upper GI, but she was able to leave the hospital and get to a rehab facility. So I want to also now switch gears to go away from leak management and fistula management and talk about my favorite group of procedures, which are the myotomies. And these are basically for sphincters that are too tight. And before you guys fall asleep, I'll bring it back to colorectal in a second. Let's talk about the per-oral endoscopic myotomy, or POEM procedure, because this is a technique that's used in a lot of different therapeutic procedures, including things like nodes. So this is an endoscopic approach for echolalia. It had started to completely replace the Heller myotomy. And during the procedure, what we're doing is we're making a mucosotomy. First, we do a submucosal lift. We make a mucosotomy proximally in the esophagus, starting about 10 centimeters proximal to the LES. We tunnel all the way down onto the gastric side. Then we pull the scope back, and that's when we start myotomizing the circular muscles. And so I will show you this video showing you the critical steps, which is really interesting. This is one of my favorite procedures of all time. So they've already done their submucosal lift. They're using an Irby TT, or I think that's the triangular tip knife. They're going to make a vertical mucotomy incision. And I'll skip ahead. Once they make that incision, they get into the submucosal space. So that's that nice cotton candy-like tissue there in front of them. The muscle is above them. They pull back, and they'll start to do their myotomy. And I think this is the coolest procedure. So here they're cutting just inner circular muscle. We leave the longitudinals behind. So how does that compare to the I drag this? The other one of my favorite is the per-oral pylori, which is the same idea, same technique, but this is for gastric. So the idea is that if you lose the pylorus, and it is consistently improved gastroparesis quality of life scores, ranging anywhere from 69 to 100%. The steps are the same. Like I said, you can do it along the greater or lesser curvature, tunnel in the space, cut the pylorus, clip on the way out. It can be a 20 to 30-minute procedure with no incisions. And this is a randomized controlled trial, which but this technique is used for Zenker's diverticulum, for post-gastric, and to come back full circle back to colorectal, it's now being used for per-anal endoscopic myotomies, or also known as per-rectal endoscopic myotomies. There's a couple of case reports in the literature. Understanding is that per-anal is described as 7 to 9 centimeter myotomy, and the per-rectal endoscopic myotomy is 20 centimeters. So the difference between the two is the distance of your myotomy. In both cases, they're used to treat Hirschsprung disease. So either failed surgical, I guess, if you still have an ultra short segment of non-functional colon, you can go in, tunnel, cut the circular muscles, and it gives patients some good relief. And this is being done. The first title I have up there is from India, the first human case in an adult. The second paper that I have cited there is a 9-year-old, and I guess she had surgery previously, and still had an ultra short segment of Hirschsprung's. So that's pretty cool, and that may be coming, in the near future. So that was sphincters that are too tight. Now I wanted to move on to sphincters that are. What do? We tighten them endoscopically. So a few procedures that I want to. A lot of them are for GERD, but for you guys, someone has applied one of these techniques through the anus for incontinent patients. So the first is the Stretta device, developed in 2000. It's a balloon catheter with 4 radial electrodes that delivers radiofrequency energy for 90 seconds to ablate the muscularis. Basically, so this is for you guys, SECA device. It's an anoscope, same idea as the Stretta, with 4 nickel titanium needle electrodes delivering radiofrequency ablation to the internal anal sphincter. 5,000 of these procedures have been done worldwide, and it just became FDA approved in the US in 2002 for treatment of fecal incontinence. So obviously it's of great interest because there's a favorable risk benefit when you compare it with sphincteroplasties and artificial sphincters. It's an ambulatory procedure. Patients can return to normal activities within 48 hours. Unfortunately, it's not been consistently shown to reduce symptoms based on quality of life scores or functional testing. So more testing is needed because it's a very promising in theory. This is going back to Foregut. Here's a device that recreates a fundoplication called the transoral incisionless fundoplication. There are 2 devices on the market now. It's basically inserted into the mouth under direct visualization of the endoscope, and it plicates the stomach to mimic a fundoplication. It does a 270-degree wrap, and the procedure achieves lasting improvement of GERD symptoms, and it's been followed out up to 6 years, and cessation or reduction of PPI medication in about 75% of patients. So this is very, very popular right now. And so on the top left, you can see a loose lower esophageal sphincter, and the bottom right is probably about 6 months after the initial procedure, and you can see it's tightened. This is a very cool procedure called the anti-reflux mucosectomy, and you guys will recognize this technique because Foregut surgeons probably stole it from you guys. This was discovered by chance when an endoscopic mucosal resection for high-grade dysplasia at the LES resulted in GERD symptom control. So here you can see that they're going to go down. This is at the LES, and they're basically taking off the mucosal layer in order to induce scarring. They do a submucosal lift, and then they band the mucosa. So that's where you guys would probably be really good at this procedure. They band the mucosa, and then they snare it off once they've banded it, much like a polypectomy. So there they are snaring it. And once they do this in a 270-degree fashion, you can see on the right, that's what it looks like immediately post-procedure. And below that is what it looks like probably a couple months after the procedure, and you see it's nice and tight to the endoscope. Basically, by inducing fibrosis, the early case series show 60 to 70% of patients are able to discontinue their PPIs after this. And one study showed that most of them did not go on to need surgical procedures. And when compared to the Nissen fundoplication in terms of quality of life scores at 3 weeks, 6 months, and even 2 years out, it was very, very similar. So this is a video just to show you how cowboy people are getting in the sphincters too loose section, and basically an advanced therapeutic endoscopy overall. So if nothing has made you anxious about any of this, wait until you see this video. This is not being widely performed, but I did see it presented at DDW. This is a per oral endoscopic fundoplication. And what they do is they start off with the same principles as POEM. So they're going to do a submucosal lift, get into the submucosal space. But then what they do, they tunnel all the way down to the gastric side, and then they exit the stomach. So this is truly this is notes procedures. They're going out in the peritoneal cavity. Here they are exiting the stomach through the serosal layer.
And once they get out there, they bring down the suture device, and they're actually going to stitch the stomach and plicate it, which is amazing, but a little insane. So even I'm nervous watching this. And you can clearly see that surgical training is going to give you an advantage over non-surgical training. So the point of my video, me showing this video, is that it's potentially difficult to do one of these if you don't perform them surgically. And so really this is why surgeons need to be kind of back in the endoscopy game. Just to mention a few awesome things, because I'm sure someone will translate this to colorectal as well one day. The endoscopic sleeve gastroplasty. So both of these are treatments for obesity. The endoscopic sleeve gastroplasty is gaining so much popularity. How many of you guys have needed patients that need an elective operation that should probably lose weight in order to make it easier and safer? And would you want to do it without incisions? Well, this is the way to do it. Essentially, what you're doing is you're plicating the stomach along the greater curvature and recreating a tube, much like you would a sleeve gastrectomy, but you're not taking it out. So you see that they're marking out where their stitches are going to go. They use this tissue anchoring device to pull the tissue in to make sure that they're getting full thickness bites, firing the needle across, and then repeating that along the greater curvature with a couple of short running sutures. And this is also a great example of use of this Apollo overstitch device. So there's been a multi-institutional trial called the MERIT trial, where they studied patients with class 1 or 2 obesity that were randomly assigned to this procedure versus lifestyle modifications, with a crossover to ESG at 52 weeks. And what they showed is the mean excess weight loss percentage at the end of the 52 weeks for the sleeve gastroplasty group was 49%, while the control group was 3%. And the total body weight loss for ESG group was 13% and control group was 0.8%. 80% of the participants in the ESG group had an improvement in one or more metabolic comorbidities, and while only 45% in the control group. So this is a very, very good procedure. And this is really, really gaining popularity. It is not replacing bariatric surgery, though, because you don't get quite as much weight loss, but it certainly is, there is a certain patient population that this will be great for. And then duodenal mucosal resurfacing. So something that's gaining interest with over 11% of Americans having diabetes, there are things like duodenal mucosal resurfacing. This is a balloon catheter device that delivers hydrothermal ablation to the duodenal mucosa and superficial submucosa, just distally to the ampulla and extending into the fourth portion of the duodenum. And in pig studies, the duodenal mucosa is completely regenerated by day 42. Pilot studies in humans show that after one ablation, the HbA1c improves up to 1 point in the first 6 months, and that is sustained until 1 year. Now, this isn't a perfect procedure in terms of resolution of diabetes, but it is the equivalent of if you had to add on a third line drug without the risk of medication side effects. So now that you all are so enamored with the advanced endoscopy and its possibilities, let's talk about where the future leads and how you all can get there. So the future of endoscopy, I have 2 words: robotic endoscopy. So this will address several pitfalls of the current endoscope. One is the need for greater stability of the camera of maneuvering the working channel instruments. Another is increased degrees of freedom. And finally, the need for tissue countertraction to perform complex endoluminal surgeries. And right now, everything is done through that working channel with no wristed movements. The flexible robotic system by Med Robotics, which is seen here at the bottom, it's been FDA approved for colorectal procedures since 2017. The tip has 2 articulated arms with 5 degrees of freedom, and also in addition to a working channel. 2 endoscopists are required for its manipulation, 1 at the tube and 1 at the command console, managing the 2 articulating arms. Most of the robotic endoscopic systems are still experimental or in the developmental stage, but one thing is clear, that endorobotics is coming. Here is an example again, the colubroscope in action. It looks just about as good as the Da Vinci single port robotic system, but can reach intestinal targets further away. So as you watch this, you have to ask yourself, how are surgeons not jumping all over this? And here it is doing a mucosal resection. So if this is the future of endoscopy, what needs to change to have surgeons be a part of this? So it largely starts with residency. Traditionally, our training had largely ignored endoscopy as a part of our surgical curriculum, but since 2018, the ABS now mandates 85 total scopes to be done in order to graduate. In early 2000s, a third of residency programs did not have dedicated endoscopy rotations, and if they did, it was a junior resident spending 1 month on that only 1 month on that dedicated rotation. I don't think that meeting these minimums should infer competency, and it's not the norm to have a chief resident ready to perform advanced endoscopic maneuvers, and we need to build a better curriculum. So what I've proposed and what I'm trying to start here at University of Alabama is following closely in the footsteps of a robotic curriculum with the goal of having chief residents prepared to learn simple advanced endoscopic maneuvers. The interns should have access to a simulator. It's not fair for them to show up and have their first touches on an endoscope, be in the OR on a patient. No offense to PGY1s, but they usually don't even know what button does what when they come to my cases, and it's not their fault. So providing a simulator for them would be step one. Once they're comfortable with the feel of the scope and mechanics, then residents should start becoming proficient in diagnostic EGDs and colonoscopies. So that's PGY2 and PGY3 years. By the time they're PGY4s and 5s, such as chiefs on their MIS or colorectal rotations, they should be able to perform more advanced techniques such as clipping for hemostasis, biopsying, etc. We do not expect you guys to be performing poems just yet. That's what fellowship is for. And what about all of those who are listening who have been through residency already, but have been so inspired by this talk that you would like to obtain some advanced endoscopic skills to add to your practice? There are plenty of postgraduate hands-on training courses offered by the ASGE, by SAGES, even by industry. And the American College of Surgeons now has a therapeutic endoscopy course that they do annually now. Unfortunately, last year, I was asked to be a part of this ACS course, and it was canceled because not enough surgeons knew about it. And I'm going to assume it was because they didn't know about it and not because they weren't interested. So some final thoughts to take home. Advanced endoscopy needs to be performed by more surgeons. We must work together with GI because although they're probably overall better endoscopists than most of surgeons at this point, we have special knowledge and awareness of basic surgical principles that have taken 5 to 7 years of training to build. More surgical operations are being supplanted or augmented by endoscopy, and we don't want to find ourselves in a world where we are losing procedures to other specialties. And finally, we need to change our current endoscopic curriculum for trainees. It can no longer be a box checked that no one cares about. So thank you, and I'll take any questions now. And sorry about the outages.
It happens all the time. It's okay. Thank you so much again for taking the time to do this tonight.
Yeah,
I
no
know
problem.
a lot of us, I mean, I think like you kind of hit the nail there. It all starts during residency, right? And I know where I came from too, we also have the one dedicated month, and there's also GI fellows. So trying to kind of balance like what does the surgery resident that's not really going to get to do a lot of this, or that's kind of what it seems like how do we
Right.
actually get them scoping more? And I feel like at a lot of places we just keep getting pushed back by GI. So just I think trying to find a strategy, like you said, in a new curriculum, I think is going to be something that's really important.
Yep. I think you guys all recognize it because I was listening to previous talks in the series.
Yeah.
And there was one by David Kleiman, right? And he was like, he posed the question, how can I maximize my endoscopic potential? Or he asked something like along those lines. And then the one before that, there was Dr. Sonia Ramamurthy, and somebody had asked actually a question in the audience about advanced endoscopy and like, should we be doing more of it? So I think it's really timely that my talk comes after those talks, and it sounds like it's an indicator that those questions were asked because everybody's starting to think about it, which is great.
Yeah. And then one question came up in terms of actual timing and who should be doing it. So in terms of like a fellowship, do you think this is something where let's say it ends up being like part of colorectal or part of MIS that you would need to have like an additional year for, or like how much time do you think would be needed to actually get proficient?
That's a good question. And I'm going to be a little biased because I did it in a year, right? And I also learned bariatric, foregut procedures, surgical procedures. I think it depends on how involved you want to be in it. I think you can learn the skills that you need to at least manage your own complications, such as anastomoses, leaks, fistula, things like that. I think you can do that within a year fellowship on top of what you're already doing. I think that's totally doable, and putting that into, let's say, the colorectal curriculums as an added part of it would be great. And I think that that's very, very reasonable. It's just a matter of getting surgeons that can do those procedures, finding them and going to those fellowships. And then as you produce more endoscopists, right, surgical endoscopists, they will go out and start teaching others. So it'll kind of just, propagate itself.
Yeah. And then I think another question that came up too is the balancing of the turf war. And if, I guess, any tips from what you've experienced here.
Yes. So I will preface this with, when I got to UAB, I wanted to make sure that there was a very civilized, amicable relationship between GI and surgery. And they assured me that there was. And I have tried to definitely include my GI, my fellow GI endoscopists, and I've asked them questions when I've had a tough case. There are meetings that we can attend together to talk about these like tough cases. So just having that collegiality is very, very important if you're a surgeon going into an institution who wants to do advanced endoscopy, because oftentimes people may feel that you're stepping on their territory. So as long as you're honest and you play nice in the sandbox, I think it can work. I know that there are institutions, I interviewed at some institutions where they were like, nope, you can't do that here, which is fine. You have to respect that. But you do have something to offer that they don't. There are different ways that surgeons think about these issues and these problems and complications. And, you can teach them things, they can teach you things, and you have to just get them to see that. But there are certainly institutions where GI would not be too happy about a surgeon coming in and wanting to do that. So you just have to play nice.
Right. And then a question from some of the fellows, for any tips for stabilizing the scope during your interventions?
Not quite sure what that means. I mean, I think just because I'm assuming you mean like, do you
Trying
need
to
a
keep it in
second?
place is like you're trying to do a polypectomy, or as you're trying to put a clip on and just
Right.
making sure it's not moving around
Yeah.
left and right,
I
up and
think
down.
I think the difference here is that most of what I do is an upper scope, which is very easy to handle.
Yep.
And you have more one-to-one control because the scope is a lot shorter. Now, if you're doing colonoscopy, I understand why you may need both your hands to do stuff, especially if you're using the working channel and you need somebody to stabilize the scope. I mean, there's no shame in using a second person if that's what you need, but as long as you can use your one hand on the dials and you don't need a second hand to do the dials, that's step one. And then, if you can, I'm trying to think about like what I would do, because it's kind of like muscle memory for me at this point. I'm not sure I can come up with any specific tips, because I probably do about 5% of colonoscopies and 95% of foregut. So I don't necessarily have that problem, but you can certainly ask a tech or a nurse to
Yeah.
hold the scope, or your resident or your intern, your medical student. I mean, they're very capable of holding the scope at the orifice if you need that, for sure.
And then with kind of going back to training residents, and I think it's always hard, I think, for attendings especially, to verbalize what they're doing with the scope too. I think it's one of the harder things to teach, because a lot of it is, like you said, by feel or by muscle memory. And I guess, do you have any tips for kind of explaining like how to properly do an endoscopic procedure, how to translate that for residents?
Yeah, that's a very good point. And I'll tell you just an example of this is that all of the residents at UAB in the operating room want to scope from the head of the bed, because that's how like ECS and thoracic all do it, right? They're standing behind the patient. And so then your view is backwards. And I'm like, you guys know that's not how, you know, most of the GI world scopes. And so I've had to really, you know, I'm in my second year of practice, but I've had to really work on using my words, and helping them get, like, even through the oropharynx, like that is a task in itself for residents, right? So I've had to learn what I know, put my muscle memory into words. I've had to pay attention to what I do, you know, and say, okay, tip down, turn your hand clockwise, you know,
Yeah.
push forward. So I use very short, direct instruction that they can easily understand in real time. But I've had to pay attention to how I do it myself, which I did not have to do in fellowship. It was kind of just do it, and then, you know, you just do it without thinking. But now
Yeah.
I had to think about it and figure it out. So yes, putting it into words is difficult, but if you get somebody who scopes enough and they've thought about this, they will be able to direct you for sure.
Okay. And then I think those were all the questions that I can see. But thanks again. If there any last minute plugs?
No, I mean, I hope that my passion for this came across. And if anybody has any questions about anything at all endoscopy, please feel free to email me. I'm sure you can find my email on the website. And I'm happy to talk about it because it is a small world, right? Surgical endoscopy is a very small world. A lot of us know each other. And I certainly want to help others if they're very interested in it. And I do encourage you guys to check out some of the courses that are available because you will get so much benefit out of it. You don't need to have a whole year of fellowship to learn how to do an endoluminal back, right? You don't need to learn how to have a whole fellowship to learn how to clip. Those are things you can learn in a course. And it will be very valuable to your practice because rather than waiting, for example, you have a leak, you call GI, they're like, okay, I can do it in 3 days. Well, you could take it yourself the same day, right? You could book it in the operating room. And so I think,
There is, sorry, there is one more question.
oh, go ahead.
With all of the, like some of the procedures that you do seem like they're pretty urgent, just like you were saying. How much of this has happened on call, or how much of these procedures do you do on call?
I would say the majority of them are not on call. The majority of them are like stable consults that I've gotten.
Okay.
I would love for people to call me if they discover a leak, you know, post-op day 1 and they want to rush them back to the operating room. In theory, I mean, the patient has to be stable. But if they're actively leaking and they have peritonitis, like I would be happy to take them back because the fresher the leak, the more chance that I have to successfully close it. I think that it's a combination of me needing to be more vocal about what I offer, right, with all services. But also, you know, people just don't usually think about it. They don't know that it exists, even within my own institution. So I would say the majority are chronic leaks, but would love to have more acute stuff that we can fix before it becomes a chronic leak.
I know if you didn't get it already, we sent you a chronic leak.
Oh, good. I think you guys have sent me multiple in the last month. So
Okay, I think that's officially it now. But again, thank you so much for your time. I know this talk got me super jazzed the first time, and I do think, like you said, it's up and coming and something we all need to be thinking a little more about, especially with endorobotics, as that kind of comes more on the scene. But for everybody else, thank you again for joining us. Remember to subscribe and to join Surgeon if you're not on already. And again, all of colorectal virtual education is shifting to Surgeon. So apologies for our kind of transition period here, but looking forward to more and can't wait for our next sessions. And thank you again to Dr. Wong. Appreciate it.
thank you guys. Have a good night.